Right now, somewhere on Earth, a stroke is happening every 40 seconds. 6 million people die from it every year. It is the second leading cause of death globally and the #1 reason people end up permanently disabled. But here's the part nobody tells you clearly enough. In the overwhelming majority of cases, the brain does not go silent without warning. It signals. It sends a message hours, sometimes days, before the catastrophic event. The problem is, nobody taught you what that message looks like. That is what this video is about. Not the stroke itself, what comes before it. Subscribe right now and hit that like button. Dr. Ethan Vale is working toward 1,000 subscribers, and every single one of you can move that number today. I have spent more than 15 years in clinical practice, watching patients arrive after a stroke and say the exact same words. I felt something strange a few days ago, but it passed. I made this video so you never have to say that. What you are about to hear is not what gets covered in a standard 12-minute clinic appointment. There is no billing code for teaching a patient to recognize a transient ischemic attack. The system does not profit from prevention. It profits from treatment. That is not a conspiracy. It is simply how the economics of medicine work. Clinics fill up with people who are already sick, not with people who could have been kept well. The entire purpose of this channel is to close that gap. Most people carry the wrong mental picture of stroke. They imagine it the way movies show it. A person standing, something dramatic happens, they collapse. That picture is not wrong for every case, but it is dangerously incomplete because what it leaves out is this. The brain almost never reaches that crisis point without first going through a rehearsal. In medicine, that rehearsal has a name. It is called a transient ischemic attack, or TIA. Transient, which simply means it passes. Ischemic, meaning the tissue was temporarily deprived of blood. It is a brief interruption of blood flow to a section of the brain that produces real neurological symptoms before reversing itself. Here's what that means inside your body. Picture the carotid artery, the large vessel running up each side of your neck, carrying blood from your heart directly to your brain. Over years, that artery has been accumulating damage from the slow, quiet process of atherosclerosis, the gradual buildup of fatty plaques along the inner vessel wall. Think of sediment building up inside an old pipe. The pipe does not suddenly block one morning. It narrows over years until one day the opening is thin enough that a small disturbance, a plaque fragment breaking free, a brief vessel spasm, is enough to stop the flow entirely, even if only for seconds or minutes. When that happens, the brain region depending on that artery goes dark. Neurons stop receiving oxygen and glucose, the two fuels the brain cannot survive without for even a few minutes. Symptoms appear. Then the fragment drifts, the spasm relaxes, blood flow returns, and the symptoms disappear. You feel fine again. You think nothing happened. But something happened, something important. What research consistently shows is that a TIA very often directly precedes a major ischemic stroke, typically within the following 72 hours. That 3-day window is the most critical period in the entire process. The brain just told you it is running out of time. Most people do not hear it because the warning episode was short, strange, and then it went away. So, before I walk you through the 5 warning signals, I want to establish one rule. Any symptom that appears suddenly, lasts a few minutes, and then resolves on its own, that pattern is the warning. The fact that it resolved does not mean you are safe. It means the clock has started. The 5 warning signals. The first warning signal: sudden darkness or fog in one eye. You were going about a completely ordinary moment, walking to the kitchen, looking out a window, and without any warning, one eye goes dark. Not blurry, dark, like a curtain dropped over it, or a frosted glass smeared across the lens. You blink, you rub the eye, and within a minute, your vision comes back. You decide you move too fast, or you need a new glasses prescription. What actually happened? A tiny plaque fragment or blood clot broke free from your carotid artery wall, traveled upward, and briefly lodged in the ophthalmic artery, the vessel supplying blood directly to the retina. When blood flow to the retina stops, even momentarily, it stops sending visual signals to the brain. That is the darkness. Not a problem with the eye itself, a problem with the vessel feeding it. Here is what makes this critical. The ophthalmic artery is a direct branch of the internal carotid artery, the same artery that feeds your brain. A 2-millimeter shift in that fragment's path puts it into a brain artery instead of an eye artery. The difference between those two destinations is the difference between a 1-minute visual disturbance and permanent paralysis. Physicians have a specific Latin term for this episode, amaurosis fugax, which means fleeting blindness. In neurology, that phrase functions like a fire alarm. When a patient describes this experience, it triggers urgent evaluation because the probability of a major stroke occurring within hours is high. Hospital records consistently show patients who experienced this visual episode 2 or 3 times over several days, dismissed each one, and then suffered a full stroke before ever being evaluated. Do not call it tired eyes. Call it what it is. The second warning signal: numbness or tingling on one side of the body with no physical explanation. You are sitting still, reading, mid-conversation, and one side of your body begins to feel strange. One arm, one hand, one leg, or one full side of your face. A pins and needles sensation, a feeling of cotton under the skin, a sense that the limb belongs to someone else for a moment. It lasts several minutes, then it fades. The medical term is paresthesia, disordered sensation in the skin. But the important point is where the disturbance is actually occurring. When a region of the brain that processes sensory signals temporarily loses blood flow, it cannot interpret information from the body parts it maps. Each brain hemisphere manages sensation for the opposite side of the body. So a TIA interrupting the right hemisphere causes the left hand, left arm, and left face to lose normal sensation. The limb itself is perfectly fine. The malfunction is inside the brain, not in the body part reporting the symptom. The detail that should sharpen your attention: stroke-related sensory changes are almost always one-sided. If both hands go numb symmetrically, the cause is more likely a cervical spine issue. But sudden unilateral numbness, one side, one limb, one cheek, appearing without any mechanical explanation and resolving in minutes, is a classic TIA pattern. It should be evaluated, not explained away. The third warning signal: sudden loss of coordination or violent dizziness with no trigger. You are walking across a familiar room and your foot does not land where your brain told it to. You veer sideways, put your hand out to steady yourself. Or it does not involve walking at all. You are sitting quietly when the room begins to spin aggressively, for no reason, without any head movement triggering it. This is the cerebellum signaling that its blood supply has been interrupted. The cerebellum sits at the base of the skull and runs constant background calculations, integrating signals from your eyes, inner ear, muscles, and joints to keep you balanced and ensure your limbs go exactly where you intend. It works automatically, without your conscious involvement. When the vessels supplying it experience a transient blockage, part of what clinicians call the vertebrobasilar system, the coordination calculations fail. You stumble, you drift, the world spins. The pattern that demands attention is specific: dizziness that is sudden, severe, and unprovoked, hitting while you are completely still without any head movement, combined with any difficulty maintaining balance or walking straight. That combination, in someone over 50, warrants a vascular workup. Isolated dizziness with a clear trigger is usually benign. The two together are a different matter entirely. The fourth warning signal: a sudden and complete breakdown of speech or language comprehension. I want to be precise about the distinction here because it matters enormously. Forgetting a word mid-sentence, the name of someone you just saw, the term that was right there a moment ago, is a universal human experience. It is not a stroke sign. What is a stroke sign is something that feels entirely different. Your speech suddenly disintegrates in a way that you yourself recognize as wrong. Words come out scrambled when your thoughts are clear, or words stop coming at all. You know what you want to say, you can feel the thought, but your mouth will not execute it. Or language coming in from another person stops making sense, as though it switched to an unknown language mid-conversation. These experiences correspond to two distinct brain regions that handle language, both typically in the left hemisphere. When the first area loses blood flow, the person knows what they want to say but cannot produce the words, what clinicians call expressive aphasia. When the second area is disrupted, the person may speak fluently but produce nonsense and may not understand what is said to them, receptive aphasia. In a TIA, either pattern can appear, last a few minutes, and then reverse completely as blood flow returns. Your home alarm going off and then silencing itself does not mean there is no fire in the building. It means you still have time to look for it. The fifth warning signal, a combination of autoimmune skin changes and new pattern headaches. This is the one most people have never heard, and the one that earns the most skeptical looks in my office. The skin condition is vitiligo, patches of skin that have lost their pigmentation, turning pale or completely white, most commonly on the hands or face. Vitiligo is an autoimmune condition where the immune system begins targeting the pigment-producing cells in the skin as though they were foreign invaders. The connection to stroke risk is not the vitiligo itself. It is the immune system behavior driving it. When the immune system becomes dysregulated in a way that leads it to attack its own cells, it rarely stops at one tissue type. In many people with vitiligo, the same inflammatory process extends to the endothelium, the microscopically thin lining of every blood vessel in the body, like a smooth, non-stick coating on the inside of every artery. When this lining is healthy, blood flows past without anything adhering. When it is inflamed and roughened by autoimmunity, by high blood sugar, by smoking, or by sustained high pressure, cholesterol deposits form, platelets cluster, plaques develop, and the vessel narrows over time. Vitiligo alone is not a stroke sentence. Many people with vitiligo live long lives without any vascular event. But if a person with vitiligo begins experiencing new headaches, unusually intense or different in character from anything prior, that combination merits a vascular evaluation rather than a wait-and-see approach. The headaches that matter here are not the ones you have had for 20 years and know completely. The concern is a headache that arrives with a new severity, a new location, or alongside any of the other 4 warning signals in this video. That is when it stops being a headache and becomes a data point in a picture that needs urgent evaluation. Now I want to tell you about a patient I will call Gerald, 61 years old, retired engineer, the kind of man who viewed visiting a doctor as something you did when things were truly broken, not merely concerning. Gerald came to me because his wife had forced him into the office. For 2 weeks, he had been experiencing what he called odd moments. 3 times his right hand had gone numb. Not painful, just absent, while typing, while cooking, and once while simply reading. Each episode lasted around 5 minutes. Each one passed. He had told his wife nothing about the first 2. The third happened while she was in the room, and she watched him go pale and sit very still before saying he was fine. He arrived with a self-diagnosis, carpal tunnel syndrome. He had researched the procedure, priced it out, and told me all he needed was a referral. I listened. Then I asked him a question that had nothing to do with his hand. Had he experienced any dizziness in the past month? He paused. Once or twice he had felt wobbly getting up from his desk. attributed it to his blood pressure medication. Had he noticed any vision changes? He hesitated. A few days ago, standing at his kitchen window, his left eye had gone foggy for about a minute. He had assumed he needed a stronger glasses prescription. Gerald did not have carpal tunnel syndrome. He had been experiencing transient ischemic attacks across 2 different vascular territories, meaning interruptions affecting more than one region of his brain simultaneously. That pattern suggests a diffuse vascular problem, possibly originating from the heart rather than a single carotid plaque. We moved quickly. Carotid duplex ultrasound showed significant narrowing in both carotid arteries. Holter monitoring, the 24-hour heart rhythm recording, revealed intermittent atrial fibrillation Gerald had never known about and never felt. His HbA1c came back at 6.8%, diabetic range with no prior diagnosis. His endothelium had been taking silent damage for years. He told me afterward that if his wife had not been in the room for that 3rd episode, he would never have come in. He would have booked a carpal tunnel consultation and waited. Gerald had an outcome that was still good, but he had been 3 episodes away from a stroke that would not have reversed on its own. Now let us talk about what is actually destroying blood vessels from the inside, because this is where the most dangerous myth in cardiovascular health lives. The myth: if my cholesterol numbers are acceptable, I am protected from stroke. Here is why that belief can get you killed. Stroke risk does not live in your cholesterol panel. It lives in the condition of your endothelium. The vessel lining can be actively degrading even when lipid numbers look fine on paper, because endothelial damage comes from inflammation, and inflammation has sources that have nothing to do with LDL levels. The first major enemy is chronically elevated blood sugar. Your endothelial cells need insulin to absorb glucose. When insulin resistance develops, when cells stop responding efficiently to the insulin signal, those endothelial cells begin to starve even while blood sugar is high. Starving cells distort and peel away from the vessel wall, leaving rough surfaces where cholesterol and platelets adhere. That is how plaques begin. This process starts in the pre-diabetes range, HbA1c between 5.7 and 6.4%, years before any formal diagnosis. Most people in that range do not know they are in it. The second enemy is tobacco. With every cigarette, toxic compounds make direct contact with the endothelial surface, triggering chemical damage and inflammation. Nicotine and carbon monoxide simultaneously make the blood thicker and more prone to clotting. A roughened vessel wall plus blood that clots more easily equals the precise conditions for a brain artery to block. Smokers carry 2 to 4 times the ischemic stroke risk of non-smokers with similar cholesterol and pressure numbers. The cigarette is not a background variable. It is a primary cause. The third enemy is blood pressure. And here is the counterintuitive part. Most people fear high blood pressure in this context, and that fear is justified. But ischemic stroke often occurs not at the peak of blood pressure, but at a relative low point. Blood pressure drops naturally during sleep by 15 to 20%. If an artery is already significantly narrowed by plaque, that nighttime dip can be enough to stop flow entirely. Which is why people go to sleep feeling completely normal and are found in the morning with a stroke that happened quietly while they slept. After 50, the rate of atherosclerotic progression approximately doubles compared to the previous decade. The same blood sugar level, the same cigarette, the same pressure reading, double the vascular consequence. How old are you right now? Write it in the comments. Your age changes which of these factors is most urgently threatening your specific vascular situation, and it changes how quickly you need to act on what comes next. The 3 evaluations worth requesting. If you recognized even one of the 5 warning signals from your own life in the past 6 months, there are 3 specific medical evaluations worth requesting by name, not vaguely mentioning, but asking for directly. The first is a carotid duplex ultrasound. Unlike a basic scan, a duplex ultrasound shows both the anatomy of the carotid arteries and how blood is actually flowing through them, including whether flow becomes turbulent at points where the vessel has narrowed. When narrowing exceeds roughly 70% of the vessel's diameter, clinicians classify that as hemodynamically significant stenosis, restrictions severe enough to meaningfully compromise blood delivery to the brain. At that threshold, the question is no longer, might a stroke occur someday? It becomes, what needs to happen now? The second is an HbA1c blood test, your 3-month blood sugar average. Below 5.7% is normal. Between 5.7 and 6.4% is pre-diabetic range, meaning blood sugar has been elevated long enough to damage the vessel lining even without a formal diagnosis. At 6.5% and above, the diagnosis is diabetes. If you have never had this test, or it has been several years since you last did, asking for it is one of the highest value requests you can make at a routine appointment. It catches vascular damage in the making before it announces itself as a stroke. The third is Holter monitoring, a 24-hour continuous heart rhythm recording. A standard clinic ECG captures 10 to 20 seconds. Atrial fibrillation, the most dangerous cardiac cause of stroke, often comes and goes, appearing for a few seconds once or twice a day, completely missed by a brief snapshot recording. In AFib, the upper chambers of the heart quiver chaotically instead of pumping. Blood stagnates, swirls, and forms clots that can travel directly to the brain. Many people with AFib feel nothing dramatic, occasional skipped beats at most, blamed on caffeine or stress. The Holter monitor catches what the clinic cannot see. And if AFib is found, anticoagulant medications, when properly prescribed and monitored, can reduce stroke risk in this condition by 60 to 70%. That is not an inevitable outcome. It is a manageable one. Here is what to do after this video ends. First, write down every unusual neurological episode you have experienced in the past 6 months. One eye dimming, a hand going absent, unexplained dizziness, words that came out wrong. Write it in plain language with an approximate date and bring that paper to your next appointment. Memory softens and rationalizes these episodes over time. Paper does not. Second, be specific with your doctor. Do not say, I have been feeling off. Say, I want to discuss whether I may have experienced transient ischemic attacks and whether a carotid duplex ultrasound, an HbA1c, and Holter monitoring are appropriate for me. Those specific words will get you a different response than a vague complaint. Third, if any of the 5 warning signals occurred within the past 72 hours, do not wait for a scheduled appointment. The 72-hour window following a TIA is the period of highest stroke risk. Go to an emergency department and tell them you believe you may have experienced a transient ischemic attack. Use that exact phrase. And fourth, do not self-administer blood thinners based on this video or anything you read online. Ischemic and hemorrhagic stroke require opposite approaches. What helps one can accelerate the other, and there is no way to distinguish them without brain imaging. Get evaluated first. Stroke is not lightning. It is not random. It is the predictable endpoint of a process that announced itself through the warning signals we covered today, through years of risk factors that were detectable and addressable. The brain was signaling the whole time. The only question is whether someone was taught to listen. Now you have been. Everything in this video is for your education and understanding, a starting point for a real conversation with your physician, not a replacement for one. Your individual history and vascular anatomy require someone who can actually examine you. If this made something complicated easier to understand, subscribe and hit like. That is how Dr. Ethan Vale moves toward 1,000 subscribers. Share this with someone who matters to you, a parent, a spouse, a friend who mentioned feeling strange lately and brushed it off. You may have just given them their warning window.